This talk is a new one. It's the first time that I give it because it's on a very innovative topic, which is precision medicine. And I will try to explain you what it is. I was trained at Harvard University about this. We had one detailed lecture about precision medicine and the role of imaging. And I try to let you know what I understood. So the idea of precision medicine is to provide the right dose of the right drug for the right indication for the right patient at the right time. Well, you would say that that's the purpose of medicine, but most of the case it doesn't happen like that. And especially in the field of psychiatry, first, well, the patient is said, well, we are not sure, you have probably depression or maybe bipolar, and we will try SSRI, and if it doesn't work, we will try tricyclic, and we will try with low dose, and otherwise we will try with high dose. So the idea of precision medicine is to go faster and to go right to the target. You have your population, and in this representation that I made, these are healthy controls in gray, and in blue it's a population of patients. But actually, whatever the disease, let's say it's a brain cancer, there are subpopulations because there are several types of brain cancer, and usually, well, in most cancer, still too much they are treated as a brain cancer or as a lymphoma, where we have a lot of kind of lymphoma or a lot of kind of brain cancer, and they should not be treated the same way. So basically in evidence-based medicine, which is what I would say the medicine of today, the idea is that you have on one side the patient and on the other side the control. That's what is done in clinical trial. We have specialists here in the room, but the problem is that the population may be very heterogeneous in the patient population. Evidence-based medicine is based on a proven relationship between diagnosis, treatment, and outcome based on very large clinical trials in patient population and meta-analysis, like people spend time looking all the PubMed study. Some people even go too far and they say that if it hasn't proved by evident medicine, then it should not be applied to patients. But the problem is that medicine is a bit more complex than that. The idea of precision medicine is that the population is subdivided into several subpopulations based on genotype, so the genome or phenotype, and we will explain it a bit more in detail. And you have the controls here in gray and several shades of blue for several subpopulations. Thus, this division into subpopulation is based on the patient's genotype, so genome, and you know the new analysis of genome, which become more and more available, and phenotype. Phenotype is the manifestation of a disease, and you will see, we will explain that imaging is one way to have information about the phenotype. Genotype and phenotype of the patient, but also of its disease, which might be a cancer. So, of both the patient and its disease, at the level of subpopulation. That's why the name was changed from personalized medicine to precision medicine, because at this step we are still at the level of subpopulations. Let's have a look at a clinical trial and let's see what's the problem. Let's say it's a measurement of atrophy, a drug against Alzheimer, let's say, and in the controls you say that the IPC hippocampal volume is quite normal for milliliter, and after the treatment, in subpopulation the drug doesn't work. You have big atrophy. In subpopulation 2, the drug seems to work actually. It's quite stable, probably not statistically significant to say that it doesn't work. And in subpopulation 3, it doesn't work. In evidence medicine, what would happen? We would make the average of the control, which is 4.2, and then the average of the whole population of everybody. And we would say, oh, no, it doesn't work. On average, your population gets a big atrophy, so the drug is not working. Why? Because the population was heterogeneous, and maybe the tests to make a good stratification of this population were not available or were not used. If we approach this via the precision medicine approach, we would say, for subpopulation 1, this drug doesn't work. There is a big atrophy, although the patient is taking the drug. For subpopulation 3, this drug doesn't work. And for subpopulation 2, and let's say it's something different in their genome, it can be a lot of differences, let's say it's a genetic variant. For this one, it works. You see that the atrophy is very low and probably not statistically significant. So what would be the conclusion? That for subpopulation 2, the drug is beneficial, it works, but not for subpopulation 1 or subpopulation 3. That's the idea of precision medicine. If we go one step further, let's say what to do for one individual. For one individual, we should check to which subpopulation he belongs to. And for that, we need more and more advanced diagnosis, genomic, but also imaging and the laboratory testing, so the whole diagnostic at the larger sense of the term. That's what we call, let's say, personalized medicine. And with that, with the same diagnosis and same prescription, we could realize that for some patients, the drug is beneficial but toxic, then we should not give it. That for some, the drug is not beneficial and not toxic. It's not toxic, but it's not useful. For some, it's not beneficial but toxic, certainly not giving to him, but to him, it's beneficial and not toxic. So it's a good candidate for the drug. That's the idea of precision medicine. And you could imagine how it can help the patient, the physician, but also the world, the social security, giving the right dose at the right time to the right patient. So what's the role of imaging? We said genotype and phenotype. Medical imaging is a proxy. So proxy is like an intermediate for phenotype manifestation of the disease. And it provides a representation of the existence of abnormalities, let's say MS lesions, which can be identified. We can identify MS lesions, enumerated, we can count them, measured, we can measure, let's say, their volume, and describe, we can describe, for example, then their shape. The whole gives what's called an imaging phenotype of the disease manifestation. Several biomarkers, and well, I summarize it here, but that's why we are describing during these 2 days. Morphology on CT or MRI, for example, the presence of lesion, their size, their number, the location, their shape, the function. We talked the whole morning about fMRI, resting state fMRI, the metabolism, PET scan. We will talk, tomorrow I will make a lecture more specific about Alzheimer's disease, and we will talk about PET scan. And Carol also spoke about PET scan in her talk. Microenvironment, tomorrow I will make a lecture about perfusion MRI, which measure the microvascularization. Magnetic resonance angiography, and molecular spectroscopy. Dr. Katsaros will make a lecture about spectroscopy tomorrow. And also molecular imaging, I will talk maybe a little bit about it. It was very trendy a few years ago in MRI, everybody was trying to do it. But now we realize that making specific contrast agent for MRI is complex. So it's more the whole of PET scan, where making targeted radio ligand is much more easy than with MRI. An example of the use of precision medicine with neuroradiology, it's a work from MGH Romero and colleagues, they use CT angiography to make prognosis of intracranial hemorrhage based on CT angiography. And they make a score from 0 to 4, and they have criteria like 1 or 2 spots on the CT angiography, and they get points depending on the dimension, the attenuation, etc. And then they calculated for this patient it was a spot size score of 3. 3 is high because it's between 0 and 4. And indeed, there was a big growth of the intracranial hemorrhage in this patient. So the spot size score is used for prognosis of patients with intracranial hemorrhage. And the subphenotype in this disease correlates with expansion and mortality. And this spot score sign is also used in a clinical trial, and especially on factor 7, which is a protective drug which try to treat the hemorrhage at the early phase. So what are the perspectives? And here I show an example of our software Imagilys. Wojciech will make a demo making measurement of brain atrophy, and my example was with Alzheimer's disease. So our software would be relevant in this case, and it's our intention at Imagilys to really go in the direction of precision medicine. It can help in the diagnostic and also what's called the diagnostic. Diagnostic is trying early in the treatment to check if the treatment works or not. Let's say for a tumor, it's easy. You can check after a few weeks if the tumor shrinks or not. And that's what, for example, is used in this new breakthrough FDA therapies, where you try to see very quickly if there is a response or not. But for disease like MS, although it might be more complex because these are long-term disease, I think there is a role for neuroimaging in precision medicine. And also in clinical trial, patient stratification to avoid this effect that I showed you, where the clinical trial as a whole failed, where actually the drug was beneficial for at least one of the subgroups. And like President Obama said in his State of the Union address, that he was launching a precision medicine initiative, which he describes as a new area of medicine, one that delivers the right treatment at the right time. Thank you for your attention.